So good morning, everybody. So as I had warned you yesterday, I was going to be back today, and here I am. The Warm Up Act, so hopefully can get you thinking a little bit about urinary tract infection surveillance and definitions for what is to come for the rest of the morning. So really, this is an opportunity to present just a portion of the healthcare associated infection data that we collected as the point prevalence survey in nursing homes that we at CDC conducted in 2017. And I had gone over this yesterday, but really this is just to remind you that one of the main objectives of doing the point prevalence survey was to measure the number and the proportion of HAIs in U.S. nursing homes and look at what the distribution of the HAI types is to really help answer of all of the different HAI types that are out there for nursing homes. Which ones are most common, which ones are least common, and which ones maybe that we're not focusing on and perhaps we should. And as a reminder, we did this using the revised McGeer criteria for residents in long-term care. And so this is a screenshot of that paper that was published in the journal Infection Control and Hospital Epidemiology in October 2012. And I suspect that many of you are familiar with these definitions. They have original McGeer criteria have been around for a very long time and are a common use for infection surveillance in nursing homes. And there were the revised definitions published in 2012. And these are the definitions that we elected to use for the purpose of doing the point prevalence survey. And so just so that you're familiar with the different types of infections that we looked at for the point prevalence survey based on these standardized set of definitions. So we had urinary tract, looking at both symptomatic UTI and catheter-associated UTI, which I suspect many of you that do NHSN are familiar with if you do the UTI reporting event module. We also had a group of respiratory tract infections, so that was pneumonia, lower respiratory tract, and then cold and pharyngitis. Gastrointestinal infections, we had a gastroenteritis, a CDI, and a norovirus group. We had a group of infections that fall into skin and soft tissue, a group that fall under mucosal, and then a group that's systemic infections, and that was really looking for the rare occurrences of bloodstream infections or sepsis that get identified within nursing home residents. And so I'm just going to put up on the slide here for you very briefly the urinary tract infection definitions, because that's what most of this presentation is going to focus on, what we found related to UTI in the point prevalence survey. So there's a definition for UTI without the presence of an indwelling catheter, and the hallmark features of these surveillance definitions is that you're required to have a positive urine culture with a certain number of CFUs and certain organism types. So that needs to be present in a person who meets a surveillance definition for UTI. And then there are also other criteria that focus on localizing urinary signs and symptoms or systemic signs and symptoms, which if present in the correct combination, you would meet the urinary tract infection definition for without having an indwelling urinary catheter. Similarly, we have an infection definition for the catheter-associated UTI. One of the main differences here is that there needs to be an indwelling urinary catheter present in this individual. But additionally, there's a positive urinary culture criteria that needs to be met. And then there are also a host of either localizing or systemic signs and symptoms that also need to be present. So when met in the right combination, you meet the surveillance definition for urinary tract infection. For the point prevalence survey that we conducted, we had to put in place a definition for something that is a nursing home onset infection to identify those onset in the nursing home versus those that were present at the time a resident was admitted to the nursing home. So in addition to meeting one of the infection definitions, and with UTI, the example I just gave you, for an infection to be counted as a healthcare associated infection or be nursing home onset, the infection had to not be present at the time of the nursing home admission, and the onset, so the first sign or symptom that became present, needed to be on or after day 3 of the nursing home admission. And again, I think this is somewhat similar to some of the rules that exist within the NHSN system for identifying nursing home onset infections. So this pie chart here really represents the various revised McGeer definitions that I just showed you, and which are most common. So you may be able to see here that the biggest portion of the pie, at 32.6%, represents the infections that will fall under the skin and soft tissue infections grouping. The second most common was respiratory tract infections at 28.8%. And the third most common was urinary tract infections at 19.9%. So while within NHSN, we focus a lot on urinary tract infections, and that's very important, and there are good reasons for that, through this work that we have done and that others have done, both in Europe using point prevalence surveys or within the VA, we start to learn a little bit more about what are the other types of infections that are identified through surveillance that may be common in nursing homes. And as you had heard yesterday during the overview of NHSN, there is now planning and in the works to include some of these additional infection types within the NHSN system for people to start tracking and following within your facilities. And again, just to point out that the purpose of today is really to focus on what we have learned about urinary tract infections, again, to kind of support and help understand the NHSN urinary tract infection surveillance that currently exists. So just under a quarter, or about 1/5 of all of the HAIs that occurred, that were identified during the point prevalence survey, fell into one of the 2 urinary tract infection definitions. And just to point out why we spend so much time thinking about urinary tract infections in nursing homes, here's a similar pie chart that actually comes from long-term care facilities in Europe. So as I'd mentioned yesterday, the European CDC has a fairly long history of doing point prevalence surveys in their long-term care facilities. And this blue pie here, you can see that urinary tract infections features quite prominently among the distribution of HAI types that occur within Europe. So again, I think there are many reasons to think that perhaps what nursing home care looks like in Europe and the United States might be very different, but still in this population, urinary tract infections figures very prominently. And then I think the other place that we can look to understand why do we put a focus on urinary tract infections is, as I had mentioned, again, the Department of VA has done a series of point prevalence surveys in their community living centers. And this is data from one of their surveys, again, showing that 30% of all of the nursing home onset HAIs that were identified were symptomatic urinary tract infections. So I think at this point, some good evidence to support the need to continue focusing on and looking at UTIs that occur in nursing homes. So here's some of the data from the point prevalence survey in 2017. So overall, the UTI prevalence rate, so again, this is different from the incidence, but prevalence, so this tells us how widespread these infection types are, was 0.48 per 100 residents. So that's about what one interpretation of this measure is that on a given day in the nursing homes that participated in this point prevalence survey, about 1 in 200 nursing home residents had a urinary tract infection that met the revised McGeer definition on a given day. The vast majority of these UTI types fell into the symptomatic UTI, so that's the urinary tract infection definition without an indwelling catheter, and 20% of them were catheter-associated urinary tract infection. And I just want to take a minute to reiterate the point here that this includes what we're talking about here, only the urinary tract infections that meet the revised McGeer surveillance definitions. So again, going back to those slides that I showed earlier, you need to meet the positive urine culture criteria, and you also need to meet the localizing or systemic urinary symptoms that are present as well. So this does not include in the count positive urine cultures that a resident might have that don't have the appropriate localizing symptoms. This doesn't include people that may present with some type of localizing or systemic sign of an infection that don't have the positive urine culture criteria met. It does not include a physician-diagnosed UTI. So in many circumstances, we may have seen evidence that a physician had said this person has a urinary tract infection. If it didn't meet the revised McGeer criteria, it is not included. And we also doesn't include residents who may have been prescribed an antibiotic for treatment of a urinary tract infection, unless it also met the surveillance definition. And this is really the hallmark of doing surveillance, both in the point prevalence survey method and in the NHSN method, is that you stick to and use the standardized surveillance definition so that we can feel confident that what someone is identifying as a urinary tract infection in one facility is equivalent to what is being identified and reported as a urinary tract infection in another facility in another state. And I just wanted to bring back to you, and drive home to you the differences between the point prevalence survey approach that we used and surveillance for incident infections, which is what happens in NHSN. So in NHSN, you look at the incidence, so new cases that occur within your nursing home population over a given time period. So each month you're looking for new cases of onset of UTI that are occurring and over the course of the year. And it's looking to help you understand what is the risk of someone in my facility of acquiring an infection. Whereas the data from the point prevalence survey is giving us a prevalence rate, and this is saying at a given point in time, how many people in this facility or in these group of facilities meet a urinary tract infection definition. So two different measures. And this is really just to illustrate some of the data that comes from the NHSN long-term care facility component, which gives you incident rates, and which is a measure of risk. So of all of the urinary tract infection types, the overall rate was 0.59 per 1,000 resident days. For catheter-associated UTI, it was 2.39 per 1,000 urinary catheter days. And then for symptomatic urinary tract infections, it's 0.49 per 1,000 resident days. So just keep that in mind when you're looking at what the prevalence rate is versus what the incidence rate is from NHSN, and that these are two different measures and two different metrics, and they're telling us slightly different things. Within the net prevalence survey, because we looked at both people that met an HAI definition and people that didn't meet an HAI definition, it allows us to do some comparisons and look at some of the differences that may exist between people with and without certain types of UTIs. And on this table here, this is just to demonstrate some of those differences that exist. So we looked at both people with a UTI and without a UTI and certain characteristics. So just to orient you to the table, in the first row are people that were identified as having diabetes. So among people with a UTI, 48% of people had diabetes, where it was 32% among people without a UTI, a difference of 16%. When we looked at residents that were classified as short stay, so that really represents the post-acute care or the skilled nursing residents that are in your facility, we can see that of those people with a UTI, 34% were short stay versus 19% without a UTI. And then one of the other factors that we had looked at was the presence of a urinary catheter So among people with a UTI, 18% had a urinary catheter versus 7% without a catheter. And the reason we do these types of analyses is because they help us identify what factors may actually be important in people developing a UTI, and help us think about what prevention, interventions, or control measures we should be thinking about. One of the key factors that has been associated with identification of urinary tract infections among nursing home residents is the presence of urinary devices, and this is true not only in the nursing home setting, but also in other healthcare settings in acute care. And in our prevalence survey, so on a given day, we found that 5% of nursing home residents had an indwelling urinary catheter present. And then on top of that, an additional 2% had what we called other urinary catheters present. So that might be a suprapubic catheter, condom catheter, urostomy, or a nephrostomy tube. And then 93% had none of these urinary devices present. And then in terms of thinking about the risk of presence of devices and what your urinary tract infection incidence rate or prevalence rate might be, I think it's helpful to understand that not all nursing homes look the same in terms of what type of residents they have or what types of devices they might be using. And one of the observations that we made is when we look at all 161 nursing homes that participated in the point prevalence survey, we can see that there's some quite big differences in how likely it was that nursing home residents in your facility had an indwelling urinary catheter present. And so you can see, using this figure here, that the median percentage of residents with a urinary catheter was 6.7. But 25% of nursing homes had a use of urinary catheters that was above 9%. So there's quite a lot of distribution in terms of use of urinary catheters among nursing homes. And these are some of the factors that come into play in explaining what your individual facility incidence rate may look like with respect to UTIs. Similarly, in European long-term care facilities, they looked not at the individual facility level, but at the country level. And here we can see, looking at the countries stacked from high at the bottom to low at the top, that there's quite a lot of difference in the use of indwelling urinary catheters in long-term care facilities across Europe. And then finally, data from the VA's point prevalence survey that has been conducted looked at the use of indwelling urinary catheters among veterans that were using their community living centers. And they found that in 2005, 10.7% of nursing home residents had an indwelling urinary catheter present. And in 2007, when they looked again, it moved up just slightly to 11%. And this work from the VA prevalence survey, I think, is really useful to read and look at. These publications appear in the American Journal of Infection Control, AJIC. And some of the work that they did really helped us understand more about what is the role of the presence of devices and HAI prevalence in nursing home settings. One thing that I'm hoping you'll take away from this presentation today, and you will probably hear more about later this morning as we talk about urinary tract infection surveillance definitions and why we use them. So what I want to make clear to you that receiving an antibiotic for a UTI, so a resident in your facility that is prescribed an antibiotic for a UTI by a provider, is not necessarily the equivalent of having a UTI surveillance event. So whether that be for the point prevalence survey that we did or in NHSN surveillance. And within the NHSN surveillance component, there are criteria that are used to identify UTI events for surveillance purposes. And I think we all feel sometimes that there may be residents out there that almost meet these definitions or have some of the components, some of the criteria present, and they've also been diagnosed with a UTI by a provider, and then they're also receiving an antibiotic from a provider. But unless those criteria are met, that's not something that we want reported into the system. There are additional guidelines and criteria out there that exist and are used to guide provider decisions on when to initiate antibiotics for a suspected UTI. One example I think that is commonly used within nursing homes is the low minimum criteria for initiation of antibiotics, and that is something that is different and separate from the revised McGeer criteria. They are different because they're not intended to be for the same purpose. The NHSN and the revised McGeer criteria are used for standardized infection surveillance purposes and allow us to compare within facilities over time or compare facilities to one another. The clinical guidelines that are used to inform decisions about initiating antibiotics are really about treating individual patients or residents within a facility and are not intended to be for standardized infection surveillance purposes. So just to summarize some of the content that you have here today and focusing on urinary tract infections. So urinary tract infections is and remains one of the most common types of healthcare-associated infections in nursing homes, and we now have recent data from 2017 that helps confirm that, yes, UTI is very common among nursing home residents. So on a given day, about 1 in 200 nursing home residents has a nursing home onset UTI. And I think when you think on a given day that there is about 1.38 to 1.4 million nursing home residents within facilities, you can understand quickly how those number of UTI add up quite substantially. In the prevalence survey, we found that symptomatic UTI were more common than the indwelling urinary catheter-associated UTI. And then just as a reminder to you that the prevalence that's measured from a prevalence survey is different than the UTI incidence that's measured and used within the NHSN. The use of surveillance definitions are really quite essential to this type of work and for the NHSN surveillance to ensure that the same thing is being counted, to enable meaningful comparisons with others, and to correctly interpret changes that may be identified and occur over time. And then finally, the prevalence survey data help aid our understanding of how the UTI criterion are used and identify resident or facility level factors that are associated with urinary tract infections. And this type of additional data is really helpful to inform UTI prevention efforts and then also inform changes or updates that may be needed to the NHSN surveillance. So with that, I'm going to take the time again to acknowledge the 161 nursing homes that participated in this project with CDC and their efforts for helping this data collection occur. So thank you. I'm happy to take any questions that anyone may have. Yes.
I noticed in one of your earlier slides you had one of the criteria for in-out catheters. Yeah, as 10 to the second power. I thought there was an update on that. I just wanted to make sure I didn't have that wrong. I thought they changed everything to 10 to the fifth now.
So that may be true for the NHSN surveillance. So we were using the revised McGeer as they were published back in 2017.
Okay, I just wanted to make sure.
That may be why there's a discrepancy there.
Okay.
Thank you. You have excellent eyesight.
Sorry.
Anyone else?
That's a great quality to have. All right. Is there another question here?
I had two questions. One is looking at geographically, were there differences? Like you mentioned in Europe, they kind of went by countries, wondering if we broke that out here. And then also you showed about post-acute and skilled and short stay. I was questioning what you were thinking as to why those might have been higher. Is it because they came from a facility where they had a catheter previously, or?
Sure. So great questions. So the first one was about geographic differences. So one of the strengths of doing this work with the CDC's Emerging Infection Program is that it was done in 10 different states geographically across the country. And so while we have peeked at the data to look at differences that occur on a state-to-state level. When we designed this project, it was done in a way so that we would really only be looking at the national data together. So the ability to look at and say with confidence that this state has a higher or lower prevalence rate compared to any of the others statistically doesn't exist for us. But I will say we can peek at the data and see that there are some differences that do exist both in HAI prevalence and antimicrobial use prevalence. And I think if you go out and do a Google search or use a search engine and look for geographic differences, particularly in the use of antibiotics, there are some quite stark differences and publications that demonstrate that really is. And there's work going on to kind of understand, well, why did these differences exist? Our project was not designed to help look at geographic differences. The second question was about what we're conveniently calling short stay, which is really a term that's supposed to identify those people who are post-acute care or receiving rehabilitation and skilled nursing. So it's kind of I say it's a convenient term because it's really a proxy measure for a couple of different things that you're really getting at. So we know that a lot of these people, all of these people would have come from an acute care setting into the nursing home. And we know that receiving care in the nursing home may prime you, a resident, or set you up for acquiring an infection within the nursing home setting. So I think the distance or the proximal time between when a person has their infection onset and to their most recent hospital discharge is part of that. We also know from looking at our data that I didn't show you here today is that when we look at some of the factors that we think predispose people to getting a healthcare-associated infection, so the one that I was really pointing at here was urinary devices or indwelling urinary catheters. So that's one group of devices. There's also the use of central lines now is becoming more common in the nursing home setting. We also see people in ventilators in some facilities. We also see feeding tubes or breathing tubes that exist. And when we look at how common those device types are among the population of the nursing home, we see they're much more common in people that are short stay, recently discharged from the hospital. And that in and of itself provides inherent risk for infection. So it's probably a proxy for several different types of factors that we're still trying to understand. It's not necessary that someone is receiving short stay or skilled nursing care. It's these other things that are present that are providing the risk. Thank you, everyone.